Hi everyone, welcome to another Wednesday VMR. I'm so excited to be here with the one and only Simi. How are you doing, friend?
I'm doing great, and thank everyone for joining. And Sharmin, I used to watch you on YouTube and used to think that if I can be in the same VMR as you, and now today co-discussing with you, it's like a dream coming true, and I'm very excited.
Oh, Simi, you're so sweet, and it's an honor for me, for sure. Absolutely. A big shout out to David and Glenn. Thank you so much for scribing and doing teaching points. And Amalpreet is presenting a case today. Amalpreet, do you want to say hi to everyone?
Hello, everyone. It's me again on the VMR on the second consecutive day. My name is Anmolpreet, and I'm very excited for today's presentation and very excited to see me discuss this case. Looking forward to the VMR today.
Hey, if you ask me more, I'm all pre the better. So let's go. Second day in a row. If we can get the board up, then we can get started. Thank you all.
Okay. So I will start with the case. Um, I have divided it into around 5 to 6 aliquots. We'll see how the case goes. So it is the case of a 50 years old male who presented to the emergency department with the complaints of chest pain for 1 day prior to admission. The pain was radiating to the shoulders and back, which was accompanied with diaphoresis. He has no history of any similar episodes in the past, and there is no past comorbidity. The patient is not on any medications. Family history is not significant, and there are no known allergies. There is no history of any recent travel. The patient does not drink alcohol, does not smoke, and there is no known animal exposure. I will stop here.
Oh, amazing. What a start. Simi, what do you think so far?
Yes, a very rich post aliquot. And as for the chest pain, I'm thinking about 4+2+2 approach, thinking about aortic dissection, acute coronary syndrome, Tokotsubo or tamponade. Also thinking about any pulmonary cause like pulmonary embolism or causing about pneumothorax as well. And as for the esophageal causes, we can always think about esophageal rupture or esophageal impaction and the pain radiating to shoulder and back. What to make of that? I'm thinking maybe it is any obstruction in the vessels, or sometimes patients have stress-related pain. So that's what I'm thinking about right now. But there is no recent travel, which makes infection less likely here. So what are you thinking, Charmine?
That was beautiful, Simi, and I totally agree with you. I think when you hear like the complaint of chest pain, that is like rather like acute on onset, you know, it hasn't been going on for a long time, no prior history. You really want to, I think, about the no misdiagnoses. And like, I love also like the 4+2 and +2. What I really appreciate about that model, it doesn't forget about the esophagus, because as an internist, I often don't think about it. Because by the time I'm admitting a patient, oh, ED probably has thought about it. But I really like to make sure like we don't forget like kind of the esophageal pathologies can lead to mediastinitis, Boerhaave syndrome as well. Um, for this patient, I think, common things, and also in terms of your misdiagnosis, the system you want to focus on more is your cardiovascular system. And I think for this patient, like kind of the vascular issues is like number one, number two, number three to rule out. So are we dealing with like an acute coronary syndrome? Are we dealing with like kind of a more unstable angina, like within that spectrum of like either coronary vessel, like thrombosis, embolic syndrome, or the other thing that not to miss with kind of the radiation to the back is that is there any reason for me to concern about like an aortic dissection of some sort? And as you mentioned, then also those are like kind of the two things that off the bat that I want to make sure we're not dealing with. And then after that, as you mentioned, other cardiac etiologies, other pulmonary etiologies really come to the forefront. And I think like with the diaphoresis, oftentimes, it's a good story for ACS, right? The onset, the diaphoresis, the radiation. However, I think like, this is someone that if you're seeing them in the ED, you're just going to get the ECG and to get the troponin and get the vital signs as soon as possible to make sure you're not missing it. And the other thing that we always say, like, thinking about who this patient is and the context also really matters. So, it's 50 years old, relatively long, but if someone with a really significant family history, then you're more concerned. So I'm like curious to learn more from Anulpreet.
Wonderful, wonderful discussion. It takes me back to a case I discussed with Dr. Sharmin, and we discussed about chest pain then. So I will talk about the vitals. Blood pressure was 180 by 80. Heart rate was 78 per minute. Respiratory rate was 20 per minute. Saturation, the patient was satting 97% on room air. And regarding the physical exam, general examination of the patient, he was conscious oriented, and the rest of the physical examination was pretty much normal with cardiovascular S1, S2 was heard, no murmurs were heard. So the physical examination was basically normal in this patient. Talking about the labs, HB is 14.6 with an MCV of 89.5. Total leukocyte count was 10,500 with neutrophilia, 88% neutrophils. Regarding the platelets, they were 328,000. Talking about the serum electrolytes and renal function test, sodium was 140, potassium 4.7, chloride 102. So pretty much normal till now. BUN was 25, creatinine was 0.9. Urinalysis at the time of presentation was normal. ESR was 15. And then calcium was 9.3, phosphorus 2.47, magnesium 1.73. Talking about the LFTs, total cholesterol was 176. Total serum bilirubin was 1.64 with conjugated bilirubin at 0.18. AST was elevated at 288 and ALT was 76. Total serum protein were 6.7 and with normal albumin equals to 4. Alkaline phosphatase was 54. Regarding some cardiac biomarkers, quantitative TROP-T was sent. It was 0.487 and BNP was 57. I will take a pause here.
Awesome. Thank you so much, Amalpreet. Just so I understand, would you mind just repeating the LFTs again, like the AST, ALT, alk-phos, and the Billy?
Total serum bilirubin was 1.64,
Okay.
slightly elevated. Conjugated bilirubin was 0.18.
Mm-hmm.
AST was elevated at 288, normal being 40, and ALT was also slightly elevated at 76. Then total serum protein was 6.7. Alk-phos was 54, normal.
Beautiful. Thank you, friend. All right, Simi, what do you make of the additional information?
Yes, we have a lot more information to make some progress, and seeing that the patient's examination is normal is quite reassuring for me. But not to miss that when we have chest pain, we should always think about structures, sometimes below the chest as well, because sometimes we have radiating pain. And here we have elevated LFTs and AST more than ALT makes me think about alcohol as well. But we have no alcohol history, but still it is a good idea asking this patient again if he had some exposure. And but I think that we should still get an EKG in this patient just to be sure. And just one clarifying question, Mol, about troponin and BNP. Were they elevated or were they like normal?
So these tests were done just initially when the patient came. So the troponin was slightly elevated. Normal troponin is 0.03 in my lab. It was 0.487. in this laboratory test, and BNP was normal at 57.
Okay, thank you. So elevated troponin makes me still concerned about the heart, and EMI or ACS or EKG, I think would be very important here. And we have learned that it is always a good idea to trend the troponin as well in the patient. So I think we can trend troponin and see where the case goes. And as for the AST, LT, I can think about either if there is any history of any liver disease, or if these are just acute phase reactants getting elevated. And we also have elevated bilirubin. However, it is not significantly elevated, but still we can consider prehepatic causes, intrahepatic, and post-hepatic causes. So that's what I'm thinking right now. So please, Sharmin, share what you were thinking and fine-tune it a little.
Oh, I love it. And I think, again, as you mentioned, the no misdiagnosis, we still want to make sure this is not a patient that needs to go to the cath lab, right? So I think wanting the repeat trope and also ECG is a really great. I think starting with like the exam and like that blood pressure, what do you make of that blood pressure, Simi?
Yes, given the elevated blood pressure and also the chest pain is for 1 day, so we can think about some acute presentation. And when we are thinking about acute presentation, we can always think about any blockage or any pus. So I'm thinking about that as well, but also considering that what if this patient did not have proper medical care in the past and hypertension was an issue that was ongoing for a long time, and today just presented with chest pain. And when we have like the chest pain relating to back, not to anchor, but we can definitely consider aortic dissection as well. So that's what I'm thinking about it.
Yeah, yeah, absolutely. I love that, always if always like looking back and see if there's any other blood pressures in the system for this patient. I mean, if there's their first presentation is their first presentation, but if they've been in the system in the past to get a baseline of like, oh, is this like this is someone who has like uncontrolled blood pressure from the get-go and is always runs high, or is this like acutely elevated? And I think with like acute elevated blood pressure, one thing that is like interesting is like the pulse pressure is like pretty wide. That oftentimes like think about like aortic regurg. However, we didn't hear any murmurs, and I think if like acute aortic regurg, patients tend to be quite sick. So I doubt that's the pathology we're dealing with. You always like want to think about like kind of a dissection physiology. We always like learn that you can get like blood pressures on the both sides, which is always like, I think easy enough to do. But I would say like if it's still same on the both sides, it doesn't decrease my pretest probability when I'm like really actively thinking about aortic dissection, unless like I have another diagnosis that rise above it. So the other thing that you want to also think about if you then become more concerned about like ACS is that like that is really a lot of afterload and a lot of pressure on the heart. So thinking about, hey, if I'm worried about ACS, do I need to like bring that pressure down a little bit? But I think for now, if the patient is stable, just gathering more data, getting your ECG would be like really helpful. In terms of the labs, I'm right there with you. I think there is a little bit of an elevated trope in the setting of a chest pain that is going on for a day. And I think like following up and seeing the trend of it is going to be really informative. The AST is also interesting, right? Like AST greater than ALT elevation, it could be coming from muscles, it could come from the heart as well. Like AST, leukocytosis, all of those things are very non-specific markers back in the day before we had like troponins. So I think they still like, I think our focus is still the heart. The other thing that I often think about, like in a setting of a chest pain, that is with like a relatively like a normal exam, is that like pulmonary embolism is another one to think about, and dissection. So I think my focus in this patient remains on the vessels, whether it's like kind of the pulmonary, aortic, or like the cardiac vessels, and want to look into that a little bit more. Um, And I think I raised a great concern of like, oh, are we like, with the elevated LFTs, are we worried about like maybe a referred pain from the belly that is presenting? Like, is that diaphoresis more like kind of sepsis physiology? Possible. I think like still we gotta think about like kind of our no misdiagnosis first. And then, I've seen with like any gallbladder pathology, I've seen every kind of LFT abnormalities, not just kind of cholestatic pattern. So that is plausible, but I would say like for now, focusing on the cardiac and pulmonary symptom, having that in the back of our mind. And at the end of the day, we have to have a good explanation as to why like those LFTs are up. Any other thoughts, Simi?
Sure, I mean, that was amazing. Nothing to add to that.
All right.
Wonderful, wonderful discussion. Now, I will share the ECG with you. I think that is much awaited for the case, but can you make me a co-host for that?
Absolutely. Also, can I be real with you all? Every time there is an ECG, I immediately become tachycardic a little bit. So I don't know, Stevie, how you're feeling, but I'm a little tachycardic.
Yes, it is something I really dread about, and I'll request our friends in audience to please help me with VKG.
Uh, you're not alone, my friend. All right. What is jumping out to you, Simi?
Um, so I think here I can, as for the rate and rhythm, that doesn't stand out, but Alina just mentioned that the T waves, they are pathologic, so we can have either this is like a hyperacute T waves or something like ST elevation. I'm not sure. Please guide me more, Sharmin. EKG is not my strong point.
Oh, let's do it together. You're doing an incredible job. Yeah, I think like the rhythm looks regular to me, and I tend to like, especially, I'm more of a hypothesis-driven human. So I'm just like, what am I worried about? And my eyes immediately goes to that. And then with ECGs, as you mentioned, I have to always like force myself to also take a step back and to be like, okay, let's be systematic. But I think in the setting of like this person coming in with like chest pain for a day, elevated troponin, we were really worried about like ACS, right? So what do you make of like the ST segments in 3 and AVF, for example?
Yes, definitely, Sharmeen. I think that there are a number of causes that can cause ST elevations. We can have acute coronary syndrome, but also things like pulmonary embolism and Tokotsubo. Sometimes they can also present like that. So that is what I'm thinking about right now. Also, we have elevated troponin. We can trend it. Maybe it increases more or it gets better. But first of all, I would like to control BP for this patient and control the pain that this patient is having. And then we can see about how we can control, give either, what do you think about giving aspirin, statins, and the patient can, I think, needs to go for a cath as well. That's what I'm thinking. An echo would be helpful as well.
Beautiful. Yeah. So I think when you look at the ECG, like there's some like some segment elevations in like anterior leads. Like if you look at the one, for example, you see it pretty well, right? Like it's a bit up. And like if you look at the inferior leads, like at 3, then we have like some reciprocal ST segment changes that is like a depression. So another thing that makes it a little bit more concerning is like anterolateral. It's about in like the regions of the heart. So in general, like this is like kind of what would you say concerning for like an ACS type picture. So with this kind of ECG, like my suspicion for like an ACS is getting higher and higher because now we have like kind of reciprocal changes. We have I'm like forgetting my English in the moments, but like, 2, 3, like back to back leads that are affected. And then in the lateral leads, you have like a little bit of an elevation as well. So I think in general, you're absolutely right in this patient. I think you would want to think about ACS. I think dissection is one thing to like keep in the back of your mind as well. But I think this is someone that you want to think about, like depending on where you are, like giving the aspirin, giving high dose statin. Depending on where you are and the culture of that place, some people load with another antiplatelet as well. Some people wait, but I think this is someone that you want to call cards and you want to see if they are able to get to the like cath lab as soon as possible. You have a history that is like kind of concerning. You have a mild strobe elevation. Although like the troponin wasn't very like really elevated, but sometimes like in the setting of like acute on chronic kind of stenosis, sometimes like you don't get as high of an elevation even with like kind of an LAD lesion. But I think you have a good enough a story to really want to pursue that. And I think like echo, depending on your system, like sometimes you can get it soon, sometimes you can get it later. But I think my focus would be to kind of I think about like heparinizing this patient and starting an ACS. The one thing when we were looking at the labs that the first thing I paid attention to was the creatinine number, because in my mind I'm always like, can I scan this patient or not? Is this someone that requires a CTA? I do think in the setting of this ECG, I have like a bit of a higher suspicion for ACS type picture rather than a dissection, but that's also remains on the on the differential. And Mulpreet, anything else in the ECG that you wanted to talk about here that we didn't get a chance to talk about?
Perfect. We are going in the right direction. And I think the thing that strikes out in the ECG is the ST elevation in V2, V3, V4 with Q waves. Their pathological Q waves are present, and we see some elevations in one AVL as well. And the reciprocal ST depressions are seen in the inferior leads. So this raises high concerns for the possibility of an anterior wall myocardial infarction, that is STEMI. So, and just to clarify, the pulses were normal in both the limbs. So if we talk about the ACS, then yes, loading dose was given to this patient, which includes the dual antiplatelet, aspirin, clopidogrel, and the statins, and the unfractionated heparin or low molecular weight heparin, depending on the patient's conditions. After that, yes, we have a POCUS echo screening was also done for this patient, and which revealed a regional wall motion abnormality with an EF of 30%, mild TR, mild MR, and moderately dilated left ventricle. So this patient was taken to cath lab, and the angiography revealed single vessel disease with proximal LAD showing 100% occlusion. Recommendations for the angiography were medical follow-up and viability study of the left anterior descending LAD territory. So that was the recommendation for the patient. And the patient basically after that was discharged on dual antiplatelet therapy, statins, ACE inhibitors, bisoprolol, spironolactone, antacid, anxiolytic. So all these medicines were started for this patient. Then after 2 days, the patient again presented to the emergency department after discharge with complaints of reportedly throat pain and loss of speech. The son gave the history that he was speaking a lot since the morning. Basically, the son gave the history that he was speaking a lot and complained of throat pain in the evening. Reportedly, the pain was so severe that the patient was not able to swallow or eat the medicines which were prescribed to him. And given the recent ACS history, the son was worried that the medicines are crucial. So the son brought him to the emergency department for stat checkup. I'll pause here.
All right, the plot thickens. Seeme, what do you make of this twist?
Yes, a very interesting twist and more. And I'm thinking whether it is something we did or there was something that was already present in this patient but got unnoticed. Like, is there a complication of the procedure we did? Is there is damage to any of the nerves, or there is internal issue with the esophagus, a motility issue, or something compressing on the esophagus that is causing dysphagia in this patient? And we can always look for any history of HIV or drug use in this patient as well, because sometimes we can have esophagitis in patients with HIV as well, but also worried about the recent procedure this patient had. So would like to ask that a patient had something like this in the past, or it is the first episode and we were seeing it for the first time. What do you think, Sharmin?
Yeah, this is puzzling. In general. So I'm really glad NLP is bringing this case to us so we can learn from it. I think like going back to like kind of the finding at that last hospitalization with like kind of the echo that shows wall motion abnormalities and the approximate LAD that is like 100% occluded. I think it kind of sounds like per their assessment, they thought this is like a chronic obstruction, and perhaps the patient is like coming in with some sort of anginal. Because oftentimes, like with the proximal LAD, oftentimes I see these patients either be recommended like cabbage versus like a stent placement. And it's intriguing to me that they opted for medical management. Again, like I'm not a cardiologist. I don't have all, like I definitely will defer to their expertise. But to me, that is a little intriguing that this was only managed medically and not with a procedure. Or perhaps they were like thinking about like doing an outpatient cabbage. But like proximal LAD lesions are like I think something that sooner or later you definitely need to address. And in terms of like medications, that patient was discharged on like I think the DAP, the statin, the Spira. I'm not 100% sure the rationale behind that, but I think like this is someone that you absolutely have to be on DAP and statin. Now, like 2 days later, he's like coming in with like kind of sounds like a aphasia, dysphagia, and like maybe dysphagia is a better word for it. I think with the loss of speech, you just gotta have to think about, are you dealing with a stroke potentially? The pain with swallowing doesn't go with that. However, with like kind of the dysphagia and aphasia, that is like something that I would worry about. And I would like, I think, start with a non-con head CT to make sure in a setting of like starting DAPT, we're not dealing with a bleed. And the other thing that I always like worry about this patients with like a significant wall motion abnormality and the EF that is, oh, sorry, the EF was 30%. That's why Spire was, okay, that makes a lot more sense. Sorry, I missed the EF. Is that like, it was there like LV thrombus or something that is forming that can potentially cause, cause a stroke, like an embolic phenomenon. So I think in this person, even though the throat pain for me isn't explained, like I think my first instinct is to make sure this person didn't have a stroke, and then kind of get a better history of like where the like the throat pain is and where the dysphagia is. Is it like a more oropharyngeal? Is it more esophagus? Like to try to get sometimes like if it's safe, you can have these patients eat and see what happens. So, like, is it do they immediately cough as they're eating, or is it like more of a regurg or like the sensation of food getting stuck? So I think in order for me to make progress with the dysphagia, I think a little bit more history would be really helpful. But as I think about like my dysphagia is the way I think about it, I think about oropharynx, and then I think about esophagus, and then with the oropharynx, I think about external compression, internal compression, and also motility, and same thing with the esophagus. And the penile, as you mentioned, like oftentimes like infection, pill esophagitis, all of these things come up. Yet I'm a little bit unclear how to put the pain and the dysphagia and aphasia together. So I think I would rule out stroke, get a bit of a more history, and then kind of like take a step back to see, like as you mentioned, also making sure like you're not dealing with 4+2+2, one of those esophageal etiologies, as you mentioned, like impaction or perforation. But I think like this. So I'm not really clear if these events are related to each other. So in my mind, I would treat them as separate until like I have a little bit more of a clarity. Like a repeat vital signs would be really helpful as well. Yeah, but puzzling. All right, Anopri, what happened?
Wonderfully discussed. And to clarify this history that I have narrated to you all, it is narrated to me by the sun. So this is a subjective history given by the sun. Now, basically, we will tell you the objective part. Talking about the vitals, it was blood pressure was 110 by 70, heart rate was 80, respiratory rate was 22, saturation was 96% on room air, and the patient was afebrile at the time of presentation. General appearance of the patient was conscious, oriented to time, place, and person. HENT pupils were normal, bilaterally equal in size and reacting, no jugular venous distension, no evidence of icterus with normal conjunctiva. Cardiovascular examination was unremarkable, pulmonary examination unremarkable, abdomen was soft, non-distended, non-tender, extremities and skin were normal. Regarding the neuro examination, the patient power in both upper and lower extremities was 5 on 5. It was normal. The patient was not able to speak, but the patient responded by moving his head. And after that, we go over towards the labs. HP was CBC was pretty much unchanged from before, and electrolytes and RFT were also unchanged from before. If you want me to tell them, I can narrate the values. And ESR was also on the similar level. Regarding the LFTs, now the total serum bilirubin had come down to 0.81 with conjugated bili at 0.23. AST had come down to 44 and ALT had come down to 65. We also sent a CKMB in this patient, which was normal. It was 17. BNP in this patient was 245. And I will also share the ECG in the second admission. And actually, it was in this admission that I actually evaluated the patient. I will share the second ECG. Can you see that?
Yes, we can. All right, my friend, we're back at it. More practice. Great. Simi, do you want to like take maybe like a 30 seconds, take a look at it and let us know what you think?
Yes, first of all, I just want to say such a rich case with lots of learning, and we get to learn two EKGs today, which is wonderful. And David helped me actually. He's saying expected reperfusion changes, but as for this EKG, the rate doesn't look too slow or so too fast to me, and we do have I think P waves are also there, and as for the T waves. There are some changes in the T waves, but please, Sharmin, guide me. I can acknowledge that I have a knowledge gap here.
Oh, we all do. And like ECGs are tough, and so much of it is just kind of pattern recognition and seeing it. I am worried about these ECGs and this patient's heart. I think like especially when you look at like kind of the anterolaterals, like the V2 to V5, like the V5, like before V5, it definitely looks at the tombstone as the elevation that we're worried about. We have like the inversions, the T inversions, and I think this could be a kind of sequela of like, as David mentioned, like perfusion. But I think this is someone that I'm really worrying about, like a thrombus or like an aneurysm will change. So I think like getting a repeat echo. And I think this is someone that maybe their underlying coronary artery disease still needs to be addressed. Yeah, you can see like the T vein inversions as well. Like the SC segment elevations are actually like an anterior leads are not as dominant anymore, but like the lateral leads are making me a bit more worried. And Pri, any other thoughts on the ECG before we talk about the rest of the labs?
I think I just shifted the screens. Um, okay, I think regarding the ECG, basically, the second ECG just showed the further next changes that after the anterior wall MI, you see first you see the ST elevation, then you see the formation of Q waves, then you see the formation of T wave inversions, and then ultimately they revert back to normal and only Q waves remain. So these were the serial ECG changes which were seen in this patient. So we could see T wave inversion. So I would just say they were the next changes after the main event, coronary event, and even the CKMB, which was done in this patient to assess for reinfarct, which is better than TROP-T to assess for reinfarct, that was normal. And regarding the initial, I was not present in the cath lab when that was done, but I know that for a fact that they must have thought that the artery is chronic or subacutely occluded. So to actually reperfuse that can actually lead to reperfusion injury or stent thrombosis. There are many complications which can arise. So they planned for a viability assessment of the LAD territory that if the reperfusion would be beneficial in this patient. So that was kept in plan for this patient, and they went for an elective discharge. The patient was discharged. So now the patient comes with these complaints to us, and neurological examination is normal.
So yeah, do you want us to discuss the rest of the findings? Yeah. All right, Simi, what are your thoughts about the rest of the vitals, the exam, and also the labs?
Yes, the BP now looks better than before, and the ST elevations, they were more significant before, but not as much now. Then I loved how I was thinking about just local cause or a focal cause of dysphagia, and how you had this broad classification about focal causes as well as diffuse, and how we can think of a stroke. But I cannot put together that how this patient is well oriented, if this patient has loss of speech due to stroke, or the dysphagia and loss of speech, but patient having normal orientation. I'm not sure how to explain that, because I was thinking about stroke, that the patient was not treated with a stent, so it is just possible that we had some sort of emboli going to brain. But I think it would be a good idea to get an MRI or CT head to further understand how this patient is doing. And what do you think, Sharmin?
Yeah, I find this case very intriguing, and Wilfred, thank you for that beautiful explanation of the thought logic. It's like quite interesting to me that you're having active changes on your ECG form a chronic, what is thought to be chronically occluded. So I feel like that is the dichotomy there that, again, like I trust the cardiologist more than myself when it comes to arena 100% of the time. But it's like interesting to me that you're seeing the active changes of an MI. But I guess from what is thought to be like a chronically occluded LAD, which I feel like that dichotomy is like a little bit puzzling to me. If that wasn't the source of the MI, then the question is like why this patient is having like kind of the active changes in the ECG pattern and the necrosis that we expect. So I guess like that is like a thing that I'm puzzling. And as you mentioned, like thinking about sequelae of MI, the aneurysms, the LV thrombus, all of these things, I still think I would repeat an echocardiogram, and especially in the setting of the BNP that is now rising, I'm like worried about the heart function for this patient. And the other things like, oftentimes these are like LA enlargement, those things can cause dysphagia, but again, that would be too acute for not as acute in this scenario. So I'm still like where I am. I think the question I'm glad like this patient doesn't have any other focal neurological deficit, but I would get that CT, I would get our MRI because definitely like a strategic stroke can cause aphasia. Um, and as we mentioned, like I think a speech and swallow eval would be really helpful to better characterize like oropharyngeal dysphagia. And I think like the other question is like, this is a person that you want to get its CT imaging and to better understand like what is going on in this area, and are we dealing with like a complication that we haven't recognized yet. So that's how I am putting this together for now, given the information we have. Any additional thoughts, Simi?
No, sure. I mean, that was poetry, nothing to add to that.
All right. I'm all free as always. You have me on the edge of my seat.
Wonderful discussion. And I think we will talk about the brain imaging only in the next aliquot. Basically, when I saw this patient, he was responding with actions, with nodding. He was nodding, but then the attendant were saying that he's not able to swallow. Even we were planning an RT insertion that was difficult, the RT insertion in this patient. So with the recent anterior wall MI, we thought that we should rule out we should rule out some problem in the brain. So we definitely got an MRI in this patient. And I'm not sure if I can share it, but let me see if I can.
Such a wonderful case where we have two EKGs and now we will be starting MRI as well. So lots of learning.
This is just a snapshot, a little snapshot of the MRI, just to clarify what happened. So I'll just, that was just to actually show what was happening. I'll just stop sharing. Yeah, so basically this patient had an acute infarct in the superior division of the left MCA territory. And yeah, and do you want to say anything about it?
Simi, what is your thoughts?
Yes, just amazed by how you were able to tell earlier that it can be a stroke. Definitely something we were thinking about. And maybe it was some thought of some sort of embolus going to brain, or it was an aneurysm that formed due to low ejection fraction, and then something traveled to brain. And given the patient's proximal occlusion, it seems like a complication of the MI and the changes the patient was having in the heart, but also thinking if it was something different and the heart was different. But I think to me, both look related. What do you think, Sharmin?
Yeah, I'm impressed by how big it was, and like the patients having aphasia and dysphagia. And this kind of sounds like, not being able to eat is like, think about oropharyngeal, and that's like the most oftentimes like with acute stroke, oropharyngeal dysphagia is like what you see, and that goes with the aphasia. So I think like now we have like a answer as that probably explains the aphasia and dysphagia, although not quite the pain. So that's something I'll still track. And now the question is like, okay, why this patient had a stroke? And I think that's where like the different phases of MRI would be helpful, the location, and that's where like neurorads is always the best, because depending on the territory, how the infarct is looking, sometimes they're like, oh, we're more worried for like embolic versus like ischemic stroke. For this patient, if I have to look at the clinical pictures, I am worried about an embolic phenomenon. So I think like making sure he doesn't have an LV thrombus and then like an LV aneurysm would be kind of like my next best. The other thing you want to think about is someone has like reduced ejection fraction, they have like a unvascularized coronary artery disease, like if they have any AFib or anything like that, that could potentially cause them a stroke. So make sure this patient is on tele. And this patient, given like they already have like coronary artery disease, are definitely still at risk of like kind of ischemic strokes with the conversion. So I think like, doing your usual stroke workup is like where I would go next with this patient. All right, annual pre, what happened next?
Yes. So we actually got, again, a 2D detail echo was done initially for the patient, which the results I have told you before. Again, the 2D echo detail was repeated for this patient. The patient's EF was 30%, regional wall motion abnormality, mild LV systolic dysfunction. All the things were normal, except for one thing. We now have developed a large LV apical clot. So that was the reason it traveled to the brain and actually resulted in the formation of the stroke. And so basically the final diagnosis was an anterior wall MI complicated by left ventricular apical clot leading to acute left MCA infarct. So should I continue or I'll just wait?
Wow. Seeme, what are your thoughts?
Yes, a very interesting case, and it was the ejection fraction was not very low, but still there was this aneurysm and this clot, and I just think a very interesting case, and it was just great how Anmol presented it to us with writing with chest pain, and then we had 2 EKGs, and she just presented it in a way that we were feeling like we were actually seeing this patient every time the patient was coming to us, and just thank you, Anmol, for bringing this case. And what was it like for you caring for this patient? Sharmin, would you like to add something?
Oh, yeah, Simi, great job discussing a complicated case, and Emil Preet is a expert presenter. That was fantastic, and you're absolutely right. Like the ejection fraction is that not that low. However, I think like the emotional wall motion abnormality, like probably like the apex not being able to move blood as well is just like push at risk of stasis and clot formation. So these people tend to be at risk of like of stroke and like kind of thrombosis. I think like what is like really interesting about this case is kind of like the clinical context and how important it is, like coming in with aphasia right after like having known to have this MI really helps you clue into like, okay, what could have happened in this person that would lead to a stroke. And I think making that connection with the degree of like hypokinesis to a risk of being thrombosis and having a stroke, it's like medicine is quite interesting. Just really sad for this patient and all that has happened. I hope he will have a smooth recovery, because a 50-year-old having like a bad MI in addition to a stroke, that's like really devastating. I hope he did okay. Excited to learn more about your thoughts, Anmol.
Yeah, wonderfully discussed. I would now comment over the dysphagia and aphasia. Basically, dysphagia was a subjective symptom in this case given to us by the relative son. And aphasia, in precisely Broca's aphasia, was what we examined in this patient. So patient might not have dysphagia, it was actually aphasia. And ultimately, I think the apical clot, it can develop as a complication of MI 1 week or 2 weeks or a few days after the acute event. And when the patient presented to us, he was pain-free initially. In the first admission, he was pain-free on admission. He just presented with the ECG changes. So he was a late presentation of ACS. So it was not, it was just planned to get a viability assessment of the LAD territory to see if reperfusing that would be of any benefit. But then because I work in a cardiac emergency, I see such cases regularly. But then I saw this was very interesting to me, that why is the patient coming with the complaint of dysphagia? What is wrong? And actually the MRI having the stroke was a big surprise for me as well. And then I realized that what actually happened, the LV clot traveled up there, and that led to the stroke. So basically the neurology team was involved, and it was the patient was managed accordingly, and the patient was discharged on escitrome nicomalon that was added for this patient, along with the dual antiplatelet therapy. Um, and I think one interesting finding was that the patient had no other neurologic deficits, only the aphasia. That's it. No, none other deficits were present. So that was an interesting case for me as well, and I just wanted to bring it to the VMR. It was very well discussed, Simi. It was great discussing with you all. Thank you.
Amazing, Anilpreet. Thank you so much. Yeah, it's a very interesting case, and I think it's a lot of like nuance of management about like anticoagulation, antiplatelets, when to start those. Yeah, very fascinating case. Thank you so much for bringing it. I learned a ton and have a lot to reflect on. Simi, wonderful job. Brilliant discussion, my friends. Appreciate you so much. Thanks, David, for scribing, and Glenn, if you're ready for your teaching points.
Okay, such a brilliant case from Anmol. I got to learn a lot of things from this case. Thanks also Sim and Sharmin for discussing the case. So going straight into the teaching points. So we started with approaching the chest pain which was radiating to the shoulder. We considered cardiovascular, pulmonary, and esophageal causes, and wanted to proceed with ECG and troponin from that. And also troponin levels were important to train the levels of it. And also on examination, there's normal exam, and when then the differentials to now the liver with was elevated, ASTs, and also we thought of a referred pain as well. Now correlating it with the elevated BPs, we thought of aortic dissection, pulmonary embolism, or could be unrelated with a chronic uncontrolled BP. And usually as well, the elevated pulse pressure could mean aortic dissection, but less likely in this patient. We then went to the ECG. We saw the hyperacute T waves, features of STEMI as well. So this was in keeping with acute coronary syndrome. Other differentials was dissection and Takotsubo as well. So the important thing at this point was to manage with antiplatelets, aspirin. I saw Anmol, they also added I forgot other anticoagulants as well. And for diagnosis, do the cath lab and echo as well. So after the patient came back after admission, so we had, after discharge, he had dysphagia and dysphonia. Now, how we approached it was could be iatrogenic, or just an intrinsic abnormality, things that can cause esophagitis, HIV, and all that, and it could be a stroke as well. And we wanted to approach the dysphagia by 3 brackets: the oropharyngeal one, which is difficulty initiating swallowing, and other causes of esophageal, including the pill-induced, the functional ones. Also, we got another ECG, the second repeat, and showed ST elevation, T wave invasions, and considering a thrombus or a reprovision injury, you wanted to repeat the echo and MRI to evaluate the dysphagia and dysphonia, and the MRI showed that there's a stroke in the MCA territory, which explained the finding of dysphagia and dysphonia. And we then concluded that it's a complication of the MI. So that's all I had for the teaching. Thank you, Anmol, for brilliant case presentation.
Glenn, thank you so much for summarizing the teaching points. Great job. Thank you also so much for joining us. It's always a lot of fun to discuss and learn from you all. Thanks all. We'll see you soon. Bye.